Hello.
It's working, yep. Okay, this is the fourth in the series. Feel a little bit like Martin Dreyer, who's a multiple winner of the doozy, and he's called the Doozy Duke, and he's won, I don't know, 7 or 8 doozies, but he always said the reason he's won so many doozies is he picks good partners, because he's won more doubles or K2 races than K1 races, and I think I'm so happy with what I've picked for this week. So the guys have done so well, and I'm sure Owen's going to do the same. So Owen is a specialist with also one of these omni-competent specialists that we have. Another one we poached from Johannesburg, undergraduate and postgraduate trained there. And Owen works both at Red Cross and at Groote Schuur, does almost everything in anesthetics, from cardiacs to babies to everything. But he's also a specialist in ultrasound-guided regional anesthesia, and he's both involved in acute pain and chronic pain at Groote Schuur and across the platform. So he really is just one of these omni-competent guys. He's also my district specialist in Metro West, so we actually look after all the little hospitals and support them as well. So he really does have a finger in every pie in anesthesia, and he also a great presenter. So I'm really happy that we can grab him before he's off to the States for 2 weeks. Tomorrow lunchtime he's out of here. So yeah, over to you, Owen.
Thanks, Ant. I think you guys have seen quite a bit of the spectrum of anesthesia this week, but I think if you went to a man in the street and asked them what anaesthetists do, or what they would expect of us to do, they would say, keep me asleep, and Ant's going to talk about consciousness tomorrow, and make sure that I don't have pain. So management of pain is really one of our core functions as anaesthetists and as doctors, really. So it's not always something we get right, but it really is a core part of our job. And nobody likes pain. Maybe not nobody, but most people don't. And I would imagine that even this young lass, if she hurt her ankle, which she looks at a bit of risk, or if she had an appendicitis and had an operation, she would need as much analgesia as anybody else. So it really is something that is universal. I think everybody in this room has experienced pain. There are very few people who don't. And if you don't, there's something wrong with you. So most people experience pain. It's a universal phenomenon across species, ages, genders, and there's a common expression of pain. If you look at the face of a baby or an adult, you can see that they're in pain. And even mice and horses and animals have similar facial expressions when they're in pain. So pain is an experience that crosses species, crosses gender, crosses race, and is a universal phenomenon in people or in organisms with advanced nervous systems. So I think the other thing about pain is that I think if you look at these faces, you'll feel empathy towards them. And if I were to show you a picture or a video of someone being injured or attacked or assaulted, you would feel for that person. And I think that empathy for pain is probably one of the driving forces in civilization and the improvement of society. And it's driven the reduction in the abolition of the slave trade and social justice across the centuries, and better treatment of animals, better treatment of humans. That the aim to reduce pain is something that is common to most humans. And some of the things that we find the most undesirable in other human beings is callousness or indifference towards pain in other people, and the willingness to inflict pain for personal gain. Those are probably some of the things that we would least be happy with in our friends or family. And if the headmaster called me in and said, your child is a bit of a dunce, not good at anything, can't play sport, he's not really going to go far in life, but he's a nice chap, I'd prefer that to being called in and being told that my son was a bully and took delight in harming humans and animals. And it's easy to understand why we have pain. We know that pain serves a protective function. We know that pain is there to warn us about any damage in our body or potential damage to our body. And it's there to warn us of harmful stimuli, to make sure we avoid harmful stimuli, and to make sure we don't put ourselves in a situation where we can be harmed and decrease our chance of survival. But what's not easy to understand is the degree of pain and the severity of pain. And it's baffled evolutionary biologists such as Richard Dawkins, who struggle to understand why pain has to be so severe and so intense and why it has to go on for so long. And if you think about it, a relatively minor injury can cause quite significant pain. That if you're sticking a nail in a wall and hit your finger with a hammer, it's intensely painful, and it's painful for a long time. And it's quite difficult to understand why it has to be so severe and why it has to go on for so long. But unfortunately, it's an evolutionary pressure that has been working for millions of years, billions of years, and we are stuck with the problem of pain. And I think in our evolutionary history, there have been two major threats to our survival. The one is infectious organisms, parasites, bacteria, viruses, and the other is trauma from other human beings. This chap's about to be mauled by a saber-toothed tiger. So we've had significant evolutionary pressures working for a long time, and we've developed ways of dealing with that. So we have behavioral responses we don't like. We have disgust and fear of contamination. We stay away from anything with a bad smell. We have an immune system to fight bacteria. And we have a pain response and behavioral responses that enable us to avoid pain, to avoid trauma. And these are exceptionally powerful forces working in our lives. And unfortunately, we have to deal with it. And currently, we don't really need as much pain as we have. We have, if you go for an operation, you don't need that amount of pain. You know that you are sore. So we really need to manage people's pain. That pain becomes harmful after an operation. It inhibits your recovery, and pain in itself becomes a self-defeating mechanism. So we really need to, as doctors, manage it and make sure that it's under control. And pain is more than just a physical phenomenon. It's an experience. And people have tried to find meaning in pain for the whole of human history. It's often described as coming from an external source. So people feel that pain is being inflicted on them from outside. We see pain as a separate entity. We say, I have a pain in my elbow. It's something that there's a reason. And it's not always clear why it's a reason. If you develop arthritis in your hip, you can't see anything there, but there's pain, and you wonder why. You try to work out why. And traditionally, it's been seen as being having many causes. It may be inflicted by God as punishment for sins, perhaps the sins of your parents, or perhaps even sins in a previous life. Maybe there to purify you and to make you a better person. Maybe inflicted by the devil to try and tempt you. But pain has meaning. It's an emotional experience, and it's an experience that has meaning. It's complex. It's more than just a physical phenomenon. And we respond to pain differently. So people will try and people respond differently in terms of how much attention they pay to pain. People may try to minimize pain, downplay it, or else pay excessive attention to pain. People catastrophize. They feel pain. They think it's the end of their lives. It's going to get worse. They're never going to get better. They worry excessively. And the behavioral responses to pain in terms of withdrawing from activities and changing your behavior in terms of pain. So we deal with our pain in different ways. There's saying no pain, no gain. The US Marines say pain is weakness leaving the body. And I've had patients tell me, when I've asked them how the pain is, saying, doctor, I just have to deal with it. I'm a man. So pain, people deal with pain in certain ways, which may be adaptive or maladaptive. And pain affects us. And it influences all aspects of our lives. People who suffer pain for a significant period of time or severe pain, it's a potent precipitant of depression, anxiety, anger. People feel worthless because they're feeling pain. They feel there's something wrong with them. And it affects relationships and social functioning. So pain is severe both in its intensity and in its effects on us. And I think as doctors, we really owe it to people to try and manage pain for a number of reasons. So how does pain work? And this is Descartes. René Descartes drew this in the 17th century, and he was the first person, one of the first people to realize that the body could be compared to a machine. That if you look at the way the body functions, it's not, there are no four humors, they're mechanical things, they're pulleys and levers and pipes and tubes. And he came to the conclusion that pain worked by this very simplified pain pathway, that the fire produced molecules of heat or particles of heat which attach themselves to the patient's skin, and then this signal ran up a cord to the brain, opened a little valve in the brain, and there was a cavity with animal spirits. And those animal spirits rushed into the body and produced a behavioral response. So you would withdraw your foot from the fire, put your hand there, look at the fire, and have various behavioral responses. And this crops up a lot in the pain literature, and normally not in a good way, that people say René Descartes had a very simplistic idea of pain, and it's almost being pilloried. But what he's, it's actually fairly accurate, or quite insightful for its time. But what it doesn't show is that pain and the response is not linear. So if I turn a light on, I know that the light will go on as soon as I turn the switch, and it's going to be exactly the same brightness every time I turn it on. But pain is not like that. So you will feel a different intensity of pain from the same stimulus to what I feel, and I'll feel a different intensity depending on my circumstances. So last year I ran the gun run, and I ran into a tree, being a genius, and it was really not painful. And I got home and saw there was a huge scratch on my arm and a big bruise that was there for weeks, but it was completely painless. But if I'm awake at 1 o'clock in the morning, I'm a bit depressed, I'm tired, I'm stressed, I have a large talk to present, UCT summer school, my wife is upset with me for some unknowable reason, my children are giving me trouble. If I bump my foot on a table leg, the pain is intense. So pain and the response to pain are not necessarily directly related, but it's a lot more complex than that. And we'll see how we currently understand pain in terms of the anatomy and physiology and what is actually going on in our body when we feel pain. So there is a pain pathway, and when we have a noxious stimulus, we have receptors in our body surface that are called nociceptors, and these have quite a high threshold for stimulation. So we have a number of receptors in our body. We have receptors for heat, for cold, for touch, to tell us what position our body is. You don't have to look at your foot to know where it is. You don't have to, you know exactly where your body is in space. You can feel cold and touch. And we have pain receptors that are called nociceptors. And it takes a significant stimulus to stimulate these nociceptors, and that is called transduction. So if you cut your hand, there's nothing necessarily painful about that. It's pain is perceived in your brain. So that stimulus has to be converted to an electrical signal, and that's what happens with these nociceptors. They're converted to an electrical signal. That electrical signal goes to your spinal cord, and that is called transmission, the transmission of the signal, and it gets transmitted up the spinal cord and into the brain, and it goes into various parts of the brain, which we'll have a look at just now. So there's transmission, transduction, transmission, and perception. So once it gets to your brain, you perceive the pain, and you perceive it as a physical phenomenon. You also have emotional responses. It projects to multiple parts of your brain. But there's also a descending pathway. So we have a part of our midbrain that's sending nerves down the spinal cord to act on those same parts of the spinal cord that are receiving the pain from the painful stimuli from the periphery, and we have a way of damping down the pain to keep it under control. So in terms of physical transmission, those four processes are what's going on. But there's no pain center in the brain. So in your brain, there are a number of centers. There's a center that controls your heart rate, and there's a center that controls your blood pressure. There's a center that controls your breathing. There's a speech center. There's a center where you hear, and there's an occipital cortex, a visual cortex. But pain, there's no pain center. Pain is felt throughout the brain. And if you look at a functional MRI of the brain, that all these bits light up with a painful stimulus. That it's not, and you can imagine that that's quite difficult to treat. That there's a whole huge part of your nervous system is involved with a pain response. That this is called the pain matrix, and all of these bits of your brain and spinal cord are active when you are experiencing pain. And we need to somehow deal with that. Now, for those of you who are not medically trained, you might find this a bit intimidating. And for those of you who are medically trained will know that you can quite safely ignore most of it and still have quite a good understanding. I'm not really putting this up for the details and the minutiae. What I want this slide to show is that there are a lot of chemicals and a lot of proteins, a lot of receptors involved in the pain process. And the way these signals travel along your spinal cord and along the peripheral nerves. And what that means is that if we need to treat pain, we need a lot of drugs. That we need drugs to act at all of these different sites to help us manage pain. That there's serotonin and mu receptors and alpha receptors, and if we block one little bit, we're going to have another receptor activated. So when we treat pain, we're going to need a lot of drugs, and we may need a combination of drugs to treat pain. The other thing that this slide doesn't show is that these receptors are not just involved in pain. Your brain doesn't say, I'm going to put an opioid receptor on that cell because that is dedicated to pain, but your body is very efficient in its use of receptors, and these things are found throughout your central nervous system. So when we give something to stop you feeling pain, it will have other effects on other parts of the nervous system, and more than the nervous system. So where morphine works, on the morphine receptors, the opioid receptors, they're found in the gut, they're found on immune cells, they're found throughout the body. So there's no magic bullet that is just going to take pain away, unfortunately. And this is the worst, possibly the worst thing about pain. And also, I don't want you to, I don't want myself to memorize this, that's for sure. And it's not really about the detail, but what this tells, there's a process called central sensitization. And what that means is that pain has effects on your spinal cord that makes pain worse. That pain basically creates pain. And what happens is that with the transmission of painful stimuli, you activate immune cells in your spinal cord, you activate the supporting cells in your spinal cord, and you get an inflammatory process, neuroinflammation going on, and pain becomes self-sustaining. You wind up the spinal cord, you get sensitization, and with long-standing pain or severe pain, you can get pain that really becomes unhooked from the original stimulus and becomes its own entity. And you may get people who have an operation, the operation heals, everything looks fine, but they still have pain. It's pain that's outlived its usefulness. It's become its own disease, really. And this is really the worst, possibly the worst thing about pain, is that it creates more pain. And this is really what we want to prevent as anaesthetists and try and treat when it happens. So I'm not sure I think I might have painted a bit of a bleak picture, but probably in 2016, this is probably the best time in history to be experiencing pain, that we understand the pain pathways, we understand the chemistry, we understand the anatomy a lot better than at any time in history before. We have the most resources dedicated to pain management more resources than have ever been dedicated to pain in history. We have drugs, we have techniques that are being developed and refined all the time. So if you are suffering from pain, you're a lot better off than you would have been 10 years ago, 20 years ago, and certainly 200 years ago, where we didn't even have Panado. So this is probably as good as it gets for now, and hopefully we'll get a lot better. So when it comes to pain, when we deal with pain in terms of the practical nitty-gritty, we want to assess what type of pain it is, how bad it is, and then make a plan to deal with it. So when we look at pain, we want to know, is it acute? Is it pain that's just happened because you've been injured? Is it pain that's acute because you've had an operation? Or is it chronic pain? And it makes a big difference in the way we allocate resources and also in the treatment. That what works for an acute pain, for an injury, will not work for pain that's become self-perpetuating, that is a patient who's been centrally sensitized and the pain is basically out of control. That needs different techniques, different drugs, different expertise. And then you want to know what's causing that pain. Is it coming from an organ inside your tummy? Is it coming from your hand? Is it simple nociceptive pain that we can understand easily and treat? Is there an inflammatory component? And neuropathic pain is our enemy. That nerve injury, nerve damage, that pain becomes difficult to treat, requires different drugs. It's something we really want to try and prevent and identify early and treat it in a different way. And then you get other types of pain, like central pain. You get some pretty unpleasant pain syndromes, which we're not going to go into. Now, when we assess pain, I've told you that pain is complex. It's got emotional components. It has physical components. But we, as doctors, like to make things very simple. So we try to reduce it to a simple score out of 10. And so I'm not sure if any of you have ever experienced a doctor asking about a pain score. I particularly hate the pain score because I think it's very difficult to understand. So what typically the way we would want the patient to answer us, or the way we would describe it, is to describe your pain on a scale of 0 to 10. 0 is no pain, and 10 would be the worst pain you could possibly imagine. So it would be like being set on fire. And we would think that from 0 to 3 is just pretty mild, like a toothache. 4, 5, 6, it's pretty bad. 8, 9, and 10, it's really becoming severe. But I think people find it very difficult to communicate in this way, that I'll have two patients sitting next to each other. One chap, I'll ask him, how's your pain? He'll say, it's quite bad. I can look at the chap, he's clearly in pain. He can tell me that he can hardly move, he can't think of anything else. His pain is dominating his life, it's relentless, and he'll give me a pain score of 7 out of 10. I'll move on to the next patient. She's sitting on her cell phone. I'm more of an irritation than anything else. She's listening to music. She tells me pain's fine, 7 out of 10. So it really becomes quite tricky. And some people would think, well, if 10 out of 10 is like being set on fire, 3 out of 10, so 30% of being set on fire is pretty severe. So some people would think that 3 out of 10 is severe. Some people think 7 out of 10 is mild. And we're trying to distill a very complex process into a simple score. So unfortunately, I actually abandoned it. What we really want to know is, how does this pain affect you? And we need to know what to target before the operation. And you need to know what to expect. And what we really want is pain that's what we really probably will not be able to take pain away after most operations. That pain is there. It's impossible to eradicate most of the time. And it does serve a function. But we want to know that your pain will be a background pain. If you want to have a conversation with your family, you can do that. If you want to read a book, you can do that, or watch TV. If you need to cooperate with your physiotherapist, you can do it. So we need to have some way of targeting pain management and then to communicate with our patients. But it sometimes can be quite tricky for me to understand what another person is going through, because pain is subjective and it's intensely personal. So there's nothing objective. So if I want to know if someone has anemia, I can do a blood test and I see that the hemoglobin is low. But if I want to know if their kidneys are working, I can test chemicals in the blood. But I cannot do a test that tells me how much pain someone is suffering. So for me to understand how much pain someone is in is quite tricky. And I actually find this one of the most difficult parts of my job, really, assessing pain. It takes time, and it can be quite difficult. So what do we do about pain? And that's really where, as an anaesthetist, this is what we do on a day-to-day basis. And if we're going to manage people's pain, it really needs to start before the operation. And I'd be interested to know if anyone has had an operation before and their pain management was addressed before the operation, because it's something we don't often do. And we have a lot of time pressures, for one thing, that as anaesthetists we may see the patient, if we're lucky, the day before an operation. If we're unlucky, in theatre before the operation. There's very little time to discuss, and to discuss pain management is quite difficult and time consuming. And also doctors are not always trained for that. So an orthopedic surgeon will be trained to look at a joint and decide what operation it needs, or look at a fracture. An anaesthetist is thinking about how he's going to manage your heart, that you had a heart attack last week, and how to manage your diabetes, and really to deal with the social aspects of pain and the psychological aspects of pain is not always easy for us, and it's a bit of hit and miss. That you might have a doctor who's particularly compassionate and naturally good at dealing with psychological issues, or you may have a doctor who's really not. And we don't get tested on that. They don't let us pass our exams because we're nice. You pass your exams because you know lots of things and you can do technical, you have academic knowledge. So what we really want to do preoperatively is identify patients who had high risk for pain, for severe pain, and people who would go on to get chronic pain. So one of our least desirable outcomes is for people to have an operation and then develop pain after the operation. And we do see it at people who have hernia repairs, even cosmetic operations like breast reductions, elective stuff like vasectomies. Some of those patients will go on to have pain for a long time from a simple operation that they could possibly have lived without. And we want to know how people deal with pain. Do they catastrophize? Do they have pain in another part of their body? If someone goes for an operation for their knee that's sore, the fact that they've had pain for a long period of time means they're more at risk of having pain afterwards. So we need to treat that pain as well as possible. And then psychological preparation is, I think, particularly poorly done. And I think we probably could do some quite simple cognitive interventions, teaching people how to think more coping thoughts, stopping thoughts like catastrophizing, thinking, I'm never going to get better, this is going to be terrible, the pain's going to be severe. So to concentrate on positive outcomes, blocking thoughts that are harmful, and behavioral things like deep breathing exercises. And I think, to me, this is probably one of the ways in which we could probably improve our practice dramatically without requiring a lot of extra resources and money. But I think it's something that's done particularly poorly. Once we get to the actual operation, intraoperative and postoperative, we really have a couple of options. And the one option is drugs, and the other option is regional anesthesia. So we can do nerve blocks. And there's some basic drugs that we use. And the drugs we use target different parts of the pain pathway. And as I said, we like to use a number of different drugs to target different parts of the pain pathway. So some of these drugs will be familiar to most people. Local anesthetics, like when you go to the dentist or have a simple procedure done under local anesthetic, a wound stitch. Anti-inflammatory drugs like Brufen, we use these commonly, Voltaren, and morphine. They all act at different parts of the pain pathway, and what we're hoping to, with our multimodal analgesia, is to try and improve pain relief and decrease side effects. So this is the poppy, Papaver somniferum, and this is where morphine comes from. So quite common in Afghanistan and Pakistan, but more for other purposes. So heroin comes from here, morphine comes from here, and now we have a whole lot of synthetic drugs like morphine that are really the best in terms of drug treatment. These are the best drugs that we have for pain management. That if you have severe pain, you'll most likely get morphine or something like that. And they're quite versatile as well. We can give them orally, we can give them as an intramuscular injection, we can put it into the epidural space for prolonged pain relief, and people have injected morphine into knees after knee scopes. That really, these are commonly used drugs and are really the best type of drug that we have to give to people apart from local anesthetics. But we're quite restricted with our morphine and these drugs, and the problem is that these drugs are pretty dangerous. They have a number of troublesome side effects: itching, vomiting, constipation, not life-threatening but unpleasant, and then they have life-threatening complications like depressing your breathing, making you breathe slowly, and possibly stopping breathing altogether. So we really want to find other ways of other drugs that we can use to limit the amount of morphine we need. So this is someone who would have a patient-controlled analgesia pump, which is sort of the Rolls-Royce of the way we would administer morphine. She's got a little computer and a little bag of morphine. Whenever she feels pain, presses a little button, gets a little dose, and then there's safety mechanisms in that pump to prevent overdose. So very nice, patients love it, good acceptability. The nurses don't have to get involved, they can do other stuff, it frees them up for other work. But you could imagine that thing looks particularly expensive. I don't think we've got something that looks that nice, but certainly not something that will be available to everybody. Paracetamol is the GP's choice, and it's also ours. Almost everyone can get paracetamol, and I think people think of Panado as really a pretty poor drug for pain, but we give almost everyone paracetamol, and it's actually quite a remarkable drug. You can give it intravenously as well. Panado, not to be underestimated. So there are a few plants here. This is the second one, and we'll come across another plant just now. So some of our best pain drugs come from plants. This is a willow tree, and aspirin comes from this tree. Been in use for a while, and all the drugs like aspirin, Brufen, Indocid, Celebrex, Voltaren, I'm sure most people have had one of these drugs at some point. And these drugs are really fantastic, but like morphine, have significant side effects. So the problem is it works on the inflammatory response, but those molecules that it targets are also used to keep the blood flow in your kidney going, to keep your stomach lining intact, and to help your platelets and blood vessels to function properly. So we run the risk of bleeding or abnormal clotting, stomach ulcers, asthma, renal failure. So if you can take it, fantastic. So really, those are our mainstays, and there are other things that we may use in theatre or out of theatre. So we have a few other options that work on other parts of the pathway, but really those are the sort of mainstays of our drugs. So not really a huge armamentarium, if you think about it. You saw all those molecules, and we have a fairly limited number of drugs that we can use. So really it's important, how we use the drugs is really important. So if you think, it really depends on the system as to how people get their drugs. So there are a lot of political issues worldwide about access to opioids. There are a lot of countries where there is no access to morphine for cancer patients, for example, because of political reasons. A decision has been made that morphine is to be avoided in that country. You may have nursing issues that, for me as a doctor, I prescribe something, that's fine, but the nurse has to give it, and she's got a lot of other things to do. If morphine needs to be given every 4 hours, there's no way that's going to happen in a busy ward. So there are a lot of logistical issues and a lot of things that the system needs to provide in order for drugs to get from a factory to a distribution network to hospitals and ultimately to a patient. And unfortunately, there are a lot of myths that are out there. So nurses may be reluctant to give morphine to people because they think they'll become addicts. They may think that they can't give Brufen to someone because he hasn't eaten a meal. They may think that if you're getting morphine, you may not get anything else. You just need one drug for your pain. So there's a lot of issues with education and enabling the system to function. So there's one part of that pain pathway that is exceptionally simple. And I showed you at the junctions between nerves, there are a number of chemicals involved there. But on the actual nerve itself, on the sort of straight part of the nerve, there's only one molecule that's involved in electrical transmission, and that's sodium channels. So what happens is that the sodium channels open, sodium goes from outside the cell to inside, the polarity of the cell changes, and that nerve impulse travels down the cell. So if we can block the sodium channel, we can block transmission completely. And the way we do that is with local anesthetics. So when I was in my first month of anesthesia, someone told me local anesthetics are the only true anesthetic, because really that blocks pain transmission completely. And I think we're definitely seeing more of a movement towards local anesthetics, and we're going to discuss exactly how we use them and what the problems are with them. So this is the last plant for the day, and this is the coca plant, where cocaine comes from. So cocaine was isolated in the 1850s, and it has quite a fascinating history. It was used by Freud, who became an addict. A number of the doctors in the late 19th century became addicts. Cocaine was really the groundbreaking local anesthetic. People injected it into themselves. They did spinal anesthetics on each other. They used it to topicalize to put anesthesia of eyes. They poured cocaine onto nerves under vision to anesthetize nerves. It really changed pain management dramatically. Unfortunately, claimed a lot of addicts along the way. Freud even used cocaine to try and cure a friend of his of morphine addiction, which didn't end well, as you would imagine. So the coca plant is the last of our plants that's been involved in pain, or that we use for pain. And nowadays we have synthetic drugs. We don't use cocaine a lot, not professionally. We use things like lignocaine and marcaine and various drugs that you may have come across at a dentist, or you may have had an procedure with a local anesthetic. And really these things are, these local anesthetics are the best way of treating pain. So we can either just, if you're having something done in your skin, we can just put a local anesthetic in the area. We can find nerves and block nerves. So if I want to do something on the little finger, I can find the nerve that's supplying that little finger and put some local anesthetic around it, and then be able to do what I want to that little finger with complete impunity. We can block very close to the spinal cord. They're what we call plexuses, a sort of network of nerves that join together, come out of the spinal cord, form a big network, and then those provide nerves to your limbs. We can block those and make an entire limb completely anesthetic and operate on that limb with the patient awake. And we can do what we call neuraxial blocks, so epidural spinals for operations like cesarean sections, for analgesia after major operations on abdomen. We can operate on hips and knees purely under local anesthetic. And I always find it incredibly effective that you can take a syringe of 2 or 3 milliliters, inject it, and anesthetize half a body. It's quite, I still find it quite remarkable. Whereas if you want to put a whole person to sleep, you need a lot more than that. So it's really quite very efficient and very effective. So these are the ways we use of finding nerves. Clearly, we can't see the nerves. We need to have a way of finding them. So we may use it in our anatomical knowledge. You can see at the top that the lady has had various lines drawn on her, let's call it the hip, that she's been drawn on, and that person's trying to find the sciatic nerve. We have a nerve stimulator, so we can supply electrical current, and then once we see muscle twitching, we know that we're close to the nerve and inject in that area. But what we do nowadays predominantly is use ultrasound. So we get an ultrasound machine, we put it on where we expect the nerve to be, find the nerve, put in a needle, and put our local anesthetic right on the nerve. So it's a pretty sophisticated technique and pretty effective for 95% of our patients. We do have the odd failure, unfortunately. And that's the problem with local anesthetics. You never have a failed general anesthetic. You can always get a patient to sleep, but you may be unsuccessful with local anesthetics. And then this is the sort of next step with local anesthetics. So what we can do is once we've found the nerve, on the left we have an epidural, so we've put a needle in the epidural space and feeding a little catheter, and then that catheter can stay. On the other side we see a catheter that's being placed next to a nerve, and that will be used to administer local anesthetic over a period of days, and it can provide complete analgesia for a long period of time. We generally limit it to 3 days, but I met a doctor from the British Army who said they put in catheters and leave them there for weeks for people with severe trauma. So we can, under those circumstances, completely obliterate pain. There are problems with acceptability. So most people, well, a lot of people are quite reluctant to have needles stuck in them, which I think is understandable. But you might undergo a short period of discomfort for definite long-term gain. And these haven't really met with universal acceptance, even among anaesthetists, that everything has problems. And the real problems we have are with nerve injuries. So it's really something that we think about every time we do the block, that we know that we're putting a needle next to a nerve. We know that we're running a solution into there that can damage the nerve, and there's a very small risk of actually injuring the nerve, and unfortunately if that does happen, our patient won't be very happy. So there's a lot of people who would prefer not to do it, a lot of doctors who prefer not to do nerve blocks. They're quite happy to stay with morphine, and there's some patients who can't face the idea of having needles stuck in them and would rather go to sleep. And the other problem is toxicity of the local anesthetics. So I think we don't have anything that's the magic bullet. We have nothing that's free of risk, but we really have a lot of options for managing pain. So I think what the take-home message is that pain is a big problem. It's a big problem in terms of numbers. It's a problem for 100% of people, really. 20% of the world's population, or 20% of population in industrialized countries suffer from chronic pain. There are probably people here who have pain at the moment. That pain is a big problem for individuals, and it's a big problem for society. Management can be difficult and it can be challenging. And it requires a team approach. So it really requires that every patient's management has to be individualized. You have to understand the patient's risk factors. You have to understand the patient's likelihood of developing complications, and the patient really needs to get involved in that to decide which option is best for them. It has to be discussed between the surgeon, the anaesthetist, and the patient, and other people as well. Physiotherapists, all people involved in patient care should really be using a team approach to manage pain. And the system needs to function well. So we need to have people who are well educated. We need to have a responsive system that will provide what somebody needs when they need it, to minimize any problems, monitor people appropriately. So I think what it means is that pain management is not simple. It's not something that really just happens, but it can be done well and should be done well. And I think as patients and as doctors, we should be demanding that it's done well. And thanks very much. Yes?
Is there a place?
I think so. When I was a student, I joined a GP for a week who did hypnosis, and I was quite impressed. It seemed to work well. He wasn't using it for pain management. He was using it for psychological issues, anxiety, depression. But it looked, I mean, I'm not really, I haven't used it myself. I don't really know anybody who uses it. I haven't read much about it. But from my brief exposure, it seemed to work well for him. I think he was pretty good, and the patients seemed to benefit from it. So I suspect there is, but I'm not really an expert on hypnosis, but I think there is a role for it, yeah. At the back, yeah. Yes. Sorry? Oh. Yes. It helps a little bit. It does work on one of the channels that's a glutamate channel, so it does block the channel. It has a physiological effect. It's not dramatic, so you never use magnesium on its own for pain control, but we use it in conjunction with other things. So it's more like a supplemental treatment instead of a primary treatment, but it does have some beneficial effect. Yes, yellow judy. Yes. Some people would say so, but morphine has its own problems, and pain that's not well treated has its own problems. So it's very difficult. The problem is we look at things in retrospect. So we see a patient who had a nerve injury, and we think, crikey, for that person, it was a terrible outcome. But I think we don't really know. So if you take 1,000 patients and we'll say 500 of them you do a block, and 500 of them you use morphine and other drugs. We don't, so whether most people will benefit from one or the other, we don't really know. But everything has problems, that somebody will take morphine and have a significant reaction, a life-threatening reaction. And some people in the group of morphine will go on to develop chronic pain, and then you'll say, well, they should have had a block. So I think it's very difficult, and it is to a degree, it depends a lot on the anaesthetist, how risk averse they are. So some people would not do blocks for that very reason, and some patients would rather avoid it for that very reason. So it's quite difficult to weigh. It's a rare event. So for someone to develop a permanent nerve damage from a block is probably 1 in 5 or 10,000 patients, which means that 4,999 have a good result, maybe, and that one person has a bad result. So yeah, it needs to be individualized. It really depends on the risk tolerance of the patient and the doctor, the anaesthetist, and the input of the surgeon. So it's sort of quite a difficult decision because you're working with a bit of uncertainty. But yeah, I think it's a valid option to not have it. Yes. Yes, it is. It works on a calcium channel. So there's a voltage-dependent calcium channel. It's just one of those receptors on the nerve ending that allows calcium into the cell, and that channel is quite active in neuropathic pain, so pain driven by nerve injury, and we use it. It blocks that channel and breaks that cycle. So for pain, phantom limb pain is neuropathic pain, and it works quite well. Not 100% successful, but it's probably one of the most useful drugs we have for phantom limb pain and other neuropathic pain. The maximum dose of gabapentin, we use pregabalin at Curtis Q. I'm not sure actually. Usually 600 milligrams 3 times a day. We don't normally go much higher than that. Yeah. Okay. Yes. Oh, sorry, lady behind you. Yes. It recovers. So that's one of the, I suppose, advantage and problem with a block. So if I do a nerve block, it'll last 12, 24 hours, and then it'll be back to normal. So that's why we put in catheters so that we can keep giving the local anesthetic to maintain the block. There are some new drugs or coming onto market that have a long duration of action, so they might last for days, but it's generally completely reversible, that once the drug wears off, the nerve is recovered and it's completely back to normal. And hopefully by that time, the worst of the pain is over, and then it's, business as usual. Yeah. Sorry, warfarin. Briefing and there are a lot of problems. It's also a risk-benefit ratio, so warfarin is a problem, and that's why there's so many new alternatives to warfarin. And maybe in 10 years' time we won't be using warfarin anymore, I don't know. But warfarin is a problem not just with pain drugs, with a number of drugs. So sometimes you can use those drugs with warfarin. You just have to monitor more closely, and sometimes you can't. But warfarin is a particularly bad drug in terms of interactions with other drugs. Yeah, that's one of them. There are quite a few that have been released in the last 5 years that are coming onto the market. Yeah. Well, that's the problem with any drug that thins your blood. You can get too much and you'll bleed too much. So whenever you take something to prevent clotting, you are going to have a potential problem of bleeding, unfortunately. So it's all a balance. It's all a balance. Yes. Yeah. I think physical pain and emotional pain are very similar. A lot of the same parts. Yeah. Yeah, I think if you read or hear what people say about severe emotional pain, they often express it in terms of body injury. They'll say, I felt like my heart was ripped out. I felt like I was gutted. I felt like I was broken. That's the intense emotional pain activates a lot of the same parts of the brain that physical pain does, and you can actually feel physical pain from emotional pain. That emotional pain and suffering and physical pain share a lot of the same nerve pathways, and a lot of the experiences are actually quite similar in a lot of ways. Yes. I haven't. Maybe we can discuss it on Friday. We don't really use it perioperatively, so for acute pain. There are cannabis derivatives that we use for vomiting, or to prevent vomiting, and it's used for chronic pain, cancer pain, which is not really my field of expertise. And I'm not sure, the evidence is mixed as well, so whether some people find benefits, but some people don't. So I'm not really, I can't comment authoritatively on it, but I think there is a role for cannabis, particularly in cancer pain. There does seem to be a role for cannabis, but clearly the problems there are legislative to a large degree. And we don't have a huge evidence base in terms of cannabis either. Yeah. Yes. Yeah.
This is probably going to sound like I have a moral objection to painkillers. Pain plays a function, and by blocking that pain, especially if you're very good at being able to block pain, that it potentially either will lead people into risky behavior because they can't, body's not necessarily able to tell them.
Yes, so that's a very good point. So people who have a block and will not feel anything in their arm. And we have to be very careful to tell them that that arm is at high risk while anesthetized. So people can, if they have a block of their leg, they can fall and injure themselves. So there is a risk, and pain is protective, so it does happen. And even while the block's starting to work, people, you find a guy with a plaster cast, you do a block, he lifts his hand up and then hits himself on the head with a plaster cast. So yeah, people really need to know how to manage an insensate limb. And in Europe and the USA, people are being sent home with nerve catheters in situ, and using and being on an infusion of local anesthetics for days at home. So it is a definite issue in terms of management, that people need to know how to look after a limb that has no sensation, because it is a definite risk. Yeah. Any other questions? Yes.
You mentioned aspirin management. Lufron and Voltaren.
Well, those are synthetic drugs, but they're sort of in the same drug class as aspirin. So those are made chemically, but aspirin was the prototype of those drugs, and those are sort of now brought in the class. But yeah. Any other questions? Yes. I think I'm not sure, the coca plant and the cocoa plant I think are different. So I'm not sure that cocoa and chocolates, I'm not sure if about cocaine and the coca plant and cocoa and drinking chocolates. I'm not sure that they're related. And the coca plant, interestingly, it used to be, before Europeans arrived in South America, the coca plant was restricted to priests and kings, and the Spaniards basically used it, broadened its use through the population in order for people to work better, so essentially like the DOP system, I suppose, in South Africa. So it became a sort of, sorry?
It's good for the health.
Yeah, but it was quite restricted traditionally in Inca society. So the use now is more widespread than it ever was, thanks to the Spanish, unfortunately. But I'm not sure that, I think the cocoa plant is a different plant. That's COCA is the cocoa plant, yeah. Thanks very much.